and welcome to the channel. I hope that everybody is doing well today. Today I'm going to be talking all about intussusception. If you are unfamiliar, hopefully you will be more familiar with it by the end of this video. It is definitely a hot topic for the nurse practitioner boards exam, and it's also something that I just recently went through with my youngest son. This video is going to be kind of two parts. The first part, I'm going to talk about our experience, how his symptoms presented, and then the second part of the video will be more of my typical presentation, diagnosis, treatment plans, follow-up that is definitely tailored to what you need to know for your boards exam. But first, if you are new here, then hi, my name is Brittany. I am a nurse practitioner. I am also the creator of the Brittany Holzbeck NP review. It is a complete, comprehensive nurse practitioner boards review for the AANP and the ANCC exams. It is currently the most comprehensive and affordable review course on the market. It is also accredited through the AANP, so you are eligible to collect continuing education credits if you take this course. And the cool thing about that then is that even if you are already a licensed nurse practitioner, if you are in need of your CEUs, which we all know we need to maintain our licensure, then you can still take the course and collect the CEUs. It's a little over 17 credits, and that also applies for RNs as well. So if nurses, if you are watching this and you need to collect some CEUs, then you too can take the course. It's a great refresher. I'll have everything linked in the description box below. Everything for my review course is available on my Patreon. So if you go there, there's 4 different tiers. Make sure you read the description for each tier before purchasing anything, because each one is a little bit different. Okay, so let's just get into today's topic. All right, so first, like I said, I'm going to talk about my personal experience with intussusception. So if you follow me on any of my social medias, and you might have seen just recently, my middle child actually did have intussusception. My whole family, we've had a lot of viral infections this season. It's been really hard for us. It's been almost hard to even determine like when one started and one ended. They've all just kind of overlapped. It's been a really rough season. Sickness is everywhere. It's been rough. Anyway, so this last week we were coming into our spring break, or my kids' spring break, and it was actually their first day of spring break when my middle son, he is 6 years old, he had a soccer game and he was looking a bit off. So I should say the week prior to this, he had like a little bit of a cough, very mild, more just like a stuffy nose, which, like I said, it's kind of been overlapping with all the other viral infections that we've had. And so he's had a stuffy nose like since Christmas. But this day in particular, I noticed when he was playing soccer that he just wasn't seeming himself. He didn't seem as like energetic. He looked a little pale in color. His game ended and I was asking him if he was feeling sick, because I could just tell. As a mom, we know. He's definitely my tough child that almost never complains, and so when he does complain, we know he really means business. He didn't even want to say like he felt bad. He just kind of kept saying, I feel sort of good. So my husband actually took him out to our car because my other son was finishing up the game as well. While my husband was in the car, he texted me and said, Jack is puking in the car. Then I was like, oh no. Some other viral infection has found its way to our family. So we got everything together and we went straight home, and we just kind of set him up on the couch. He puked 2 more times and then it kind of subsided. He definitely didn't have as much energy, but he was laughing, joking, watching a movie with his brother. Just generally seemed like it had passed just as fast as it started. So the following day was Sunday. As the day progressed towards the evening, I want to say around 8:30 p.m., he started complaining of abdominal pain, and it came on really kind of quickly to the point where it was making him cry. I asked him, where his pain was, and he had some tenderness in his right lower quadrant. And so immediately, obviously, first thing you think of when you hear right lower quadrant pain is like appendicitis. Everyone thinks that with right lower quadrant pain. Obviously, we know that to be an emergency. I told my husband he has to take him to the ER like immediately. I had this gut feeling that something was really wrong. And so I stayed back with the baby and my older son, and my husband took him to our nearest emergency room. It was an attending physician that saw him. Really, honestly, didn't do like much of anything. I really am trying to give him the benefit of the doubt that he in his heart really just felt like it was a symptom of this viral infection, because the week before, my older son had a stomach virus where he was puking and nauseous. And like I said, we had had all these viral infections in our family. So he just immediately chalked it up to he has a virus. He was vomiting. At this point, he did develop a fever as well. He had a stuffy nose. He was coughing. And so the doctor just looked at it like as a whole as like he has a virus. He had him jump up and down, and he was able to jump. And that made the doctor feel even more confident that it was nothing serious. He'd said that he had seen appendicitis many a times, and when they have it, they're unable to do that. And so he was very confident that it wasn't appendicitis. Now, at this point, I'm texting with my husband the entire time. I'm hearing what he's telling me. This time now the pain has changed from this constant sharp pain to this really intermittent pain. Like every 30 minutes he was having a sharp pain and then nothing. We kept thinking, oh, maybe he's feeling better, and then oh, he's having pain again. Oh, he's feeling better. Oh, he's having pain again. And so the doctor, before discharging him, was pretty confident that the way that the pain was presenting was simply gas pain. And so I'm pushing for an ultrasound. My husband tried pushing for an ultrasound. The attending physician let him know that they didn't have anyone on staff to do an ultrasound. And he said when the person does get on staff, they're not very equipped to interpret pediatric ultrasounds. So it would most likely come back inconclusive anyway. And the other option, of course, is to do a CT, but the attending physician didn't want to expose him to unnecessary radiation, which I understand. Like, it's hard. The whole thing is hard, right? Because hindsight is 20/20. So they discharged him home, said it's most likely gas pain. If it gets worse, go to a children's hospital where they're better equipped to take care of kids. Jackson comes home. That intermittent pain persists. His fever persists. I give him simethicone, which is like a gas X, trying to see if that was helping him. It would be hard to tell because he'd go this interval of time where he'd have no pain. He'd almost be back to feeling good, and then he'd have this really, really sharp pain again. At this point, intussusception is definitely on my radar. I keep thinking back to the text and studying, and that was like one of those big red flag diagnoses. But it most commonly occurs in younger children. I believe it's between 3 and 36 months. It's already rare as it is, but it's even more rare in his age population. But because of the way that the pain was presenting, so colicky and so intermittent, that I just kept thinking, could that be intussusception? I didn't at the time know a ton of history on intussusception. Now I do, because I've been reading religiously about it since going through it. But I definitely, clued in on that colicky pain. Looking back now, like I said, hindsight is 20/20. I definitely have a lot of regret for not taking him to Children's Hospital right away, but I wanted to believe that the doctor was right. And again, I'm trying to give him the benefit of the doubt, although I think with the amount of pain that he was in, it would have been appropriate to do imaging, or at least strongly advise that he had imaging done. But we can't know everything all the time. Editing Brittany here. I just wanted to take a quick second. I think it's a good point here to mention that, one, if you're worried about something, always get a second opinion. It can never hurt to get a second opinion. Also, if you're worried about something, then definitely advocate for yourself or your family members. Statistics have shown that patients with family members that advocate for them and ask questions, they have better outcomes. Anyway, so I gave him the day, and I feel a lot of guilt about that because he spent the whole day with intermittent pain. And I said, if on Tuesday, if this is still going on, I'm taking him to Children's Hospital. Tuesday came and he was still having the pain. And so I was adamant about taking him to Children's Hospital and having imaging done. Best case scenario is that we drove out there for nothing and it was just gas, but I needed to know. We have no close children's hospital, which is really unfortunate. But we drove out to the nearest children's hospital, which was like 35 minutes away. And we saw a nurse practitioner there. She did an amazing job. She was so thorough. She checked him for COVID, flu, strep, because strep can sometimes present with abdominal pain, fever. And then she also did that abdominal ultrasound. Right away, I could tell that she found something just with how she was really honing in on one area. And when she was done, she said the radiologist would get right with you or interpret this right away and get right back to you. Again, with her tone, I just knew in my gut that something was wrong, and I knew that she had found something. So when the nurse practitioner came back in the room just a couple minutes later, she said, yes, he does have intussusception. I had this flood of emotions. One, I knew it. I knew that I should have trusted my instinct and I should have pushed harder and had him seen sooner, and I had a lot of guilt. Also, relief that they had an answer, and a lot of fear because I know that there are possibly some complications with this, and it's a very serious thing for a child to go through. And I had a lot of emotions at the time. They actually sent us to downtown Detroit because they are equipped for an emergent surgical procedure if need be. They called the hospital, let them know we were coming. We really didn't have to wait, but maybe like 10 minutes in the waiting room, which was nice. At this time, though, we did notice that Jackson's pain, like the intervals started to seem like they were getting closer together. He clearly was in very bad pain. And watching your child, any child, but watching your child in that kind of pain, it is honestly like heart-wrenching. I think I make it clear that, you know, my kids are my entire world. I do literally feel like they are my heart outside of my body. And when you love someone, a person that much, you are extremely vulnerable to feeling a lot of hurt because you love them so much. And so it was so hard to watch him in pain and just not be able to take his pain away. I'm digressing a little bit, but it was really hard to watch him in pain. And so we got back really quickly and they put an IV in him. He was so tough about it. They gave him Motrin, but that was the only like pain medication that he was given. First, when a child, as long as they're not showing symptoms of like shock or some kind of rupture, they will attempt non-surgical procedures first to attempt to reduce the intussusception. And so he was able to have his intussusception reduced on the first attempt with the non-surgical procedure. And in this next part of the video, I'll kind of go over the different treatment options and everything like that. Then after he had it reduced, there is an increased risk of it returning. So they kept him for 24 hours of monitoring. They said usually with younger infants, they will keep them for like maybe even 4 or 6 hours, something, a smaller amount of time. But because he was older, or is older, they wanted to keep an eye on him basically longer. Like I said, before going through this, I didn't have a ton of knowledge. I mean, I knew the surface information when it comes to intussusception. So I was researching while sitting in the hospital room, which is like the worst thing that you can do. But one thing I was really nervous about was, you know, what caused the intussusception. So if you read on Up to Date, they say 75% is idiopathic, so no real like known cause. In that lump of 75%, a lot of the occurrences of intussusception are triggered by some sort of viral infection. And then the other 25%, there's some really scary things in there that could be causing an intussusception. So they did say when we were in the children's hospital that from the ultrasound, it looked like it was a lot of swollen lymph nodes throughout his intestinal tract, which caused essentially the intestine to telescope and collapse in on itself, which would make sense because he had had so many viral infections before that he would have, you know, these swollen lymph nodes, inflammation. Also would be the best case scenario because it's not as serious as some of the other possible causes for intussusception. He was discharged the following day. There is an increased risk still of him having it happen again in the future, which is kind of terrifying. But he did have his follow-up outpatient with his pediatrician, and they did do some basic blood work, which came back perfect. And they are having him do a repeat ultrasound in 1 month. So we'll see how that looks, but he regained his appetite. He's acting himself again. So I'm just thankful that he is okay, and I'm thankful for the medical staff that took such great care of him. And he is the strongest little boy. But I'm gonna get now into the second part of the video where we just kind of break down the literature and what you would need to know in regards to intussusception for your boards exam and if you are entering into clinical practice. All right, so first, what exactly is intussusception? So intussusception occurs when part of the intestine telescopes in on itself, and it's identified as the most common abdominal emergency in the pediatric population, specifically in children younger than 2 years of age, and it peaks about between 4 and 36 months of age. So intussusception is classified by its location in which it occurs, with 90% of all cases occurring at the ileocecal junction. And as I mentioned already, 75% of the cases are actually considered idiopathic, basically meaning that the cause is unknown, with the other 25% having a pathologic origin. It is noted that when intussusception occurs outside of that normal age range, a pathologic lead point such as a lesion or a mass is more likely. So how do these patients present, and how does it compare to that picture that I just painted for you? So the textbook presentation of a patient with intussusception is an infant or a toddler with severe, intermittent, progressive abdominal pain, where the child becomes inconsolable, draws their legs towards their abdomen, and they can often also become more pale in appearance. The symptoms, they usually occur at 15 to 20-minute intervals, becoming more frequent and severe as the time progresses. Vomiting is typically present. It generally starts as a non-bilious vomiting. However, it can progress to bilious vomiting as the obstruction worsens. A sausage-shaped mass can be palpated at that right side of the abdomen. Also, grossly bloody stool is seen in about 50% of cases. Occasionally, stool will also have what they refer to as the quote-unquote currant jelly appearance, which that's definitely a buzzword for your exam. However, the reality is that this is actually a late finding, and it is actually rarely seen. So in regards to the textbook presentation, my son matched the pain episodes almost 100% with that severe, intermittent, progressive abdominal pain. However, the rest of the symptoms were not present. I mean, I guess he did have those couple episodes of vomiting, but otherwise, besides pain and fever, he had no other symptoms. And I think it's just important to point out that patients will not always match what the text says. And so we really need to use our clinical reasoning and look at each patient individually when we're building our differential. So how is intussusception definitively diagnosed? Ultrasound. Ultrasound is the preferred diagnostic choice with a near 100% sensitivity and specificity in both diagnosing and ruling out intussusception with an experienced ultrasonographer. So the classic finding on ultrasound, this is referred to as a quote-unquote target sign or a bullseye, or also coiled spring. So those are the terms that you could see in the interpretation. And here on the screen, you can see a picture of what that actually looks like on an ultrasound. After reviewing the images myself, this is exactly what my son's intussusception looked like on the ultrasound screen, and what I could see that tech was really focusing in on. Another advantage of ultrasound is that it can correctly identify a pathologic lead point in about 2/3 of cases. And then in addition to ultrasound, 2 view plane abdominal radiographs should be done to rule out a perforation. So in the case of a perforation, surgical treatment is going to be indicated for these patients. However, it should be emphasized that abdominal x-rays should not be used to rule out intussusception, only to rule out a perforation. And I don't think I mentioned this already in my first part of the video, but they did do abdominal x-rays with my son, and they did rule out any perforation. Okay, and so how do we treat an intussusception? So in most patients that have normal vitals without evidence of a bowel perforation, a non-operative reduction would be the preferred treatment. And so this is done either using hydrostatic or pneumatic pressure by an enema. Additionally, it's important that the surgical team is notified of the non-operative attempt occurring so that they can be immediately available in the case of a surgical emergency, such as a perforation occurring during the procedure. So success with these non-operative techniques is seen in about 70 to 85% of patients with an ileocolic intussusception. Success is going to be less likely in infants that are younger than 1 year of age or children older than 5 years of age, and that's due to the increased risk of a pathologic lead point. If the non-operative attempt was only partially successful, but the patient remains stable, then the literature recommends repeating the enema in 30 minutes up to a few hours later. UpToDate does say that a repeat enema should not be done in the case of patients that have a completely unsuccessful non-operative attempt, and that these patients should actually proceed promptly to surgery. And I found this interesting because in our situation, the doctor said that as long as my son remained stable, they would actually attempt that non-operative management multiple times before proceeding to surgery. Additionally, antibiotics, they are not routinely given unless, of course, the patient has any signs of sepsis, or again, if a perforation is present. And then generally these patients that have a successful reduction are monitored in the hospital for 12 to 24 hours. And then once they're discharged home, it's really important that we instruct them on symptoms to look out for that, of course, would warrant them to have an immediate return. So any symptoms, again, of intussusception like that, colicky pain, vomiting, anything like that would warrant a return to the hospital immediately. And then they should follow up with their primary care in about 1 to 2 days. Well, that is going to complete today's video. Definitely a bit longer than my usual content. Don't forget, if you are interested in my review course or anything that I mentioned in the beginning of this video, everything is linked in the description box below. Otherwise, I wish you guys nothing but the best. Don't forget to learn something new every day, and I will talk to you soon.